The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Understanding Clinical Trials and Improving Access. Thank you to today's webinar sponsor, GT Medical Technologies, for their support of this program. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Shiao-Pei Weathers is a neuro-oncologist who specializes in primary brain tumors, specifically gliomas. She has served as PI or co-investigator on numerous clinical trials for patients with newly diagnosed or recurrent glioblastoma, and is actively involved in devising new treatment strategies and combinations for these patient groups. She serves as director of the MD Anderson Neuro-Oncology Fellowship Program, clinical medical director for the Brain and Spine Center, and director of MD Anderson's Brain Tumor Support Group, Brain Tumor Education and Support Together, where she collaborates directly with social workers and practitioners on providing education and counseling support for primary brain tumor patients and their caregivers. Thank you so much for joining us, Dr. Weathers. You may now begin your presentation.
Thank you so much, Ambreen, and thank you so much to ABTA for the kind invitation to spend some time with all of you, talking a little bit about understanding clinical trials and improving access. These are my disclosures. I do receive research funding from a number of companies. And this afternoon, we're going to talk a little bit about the following items in regards to understanding clinical trial terminology, understanding who can participate in a clinical trial, learn a little bit about the phases of clinical trial development, how do you decide to participate in a clinical trial if one is presented to you, talk a little bit about the barriers that we as providers and patients have also identified as limitations in being able to be enrolled in a clinical trial, and how can we together improve access to clinical trials for our patients. So in regards to a clinical trial introduction, I really wanted to start with some foundational knowledge in regards to what is a clinical trial. It's often a buzzword in terms of oncology in regards to hearing about clinical trials in essence, but what does that really mean? So clinical trial refers to a research study where patients or folks are volunteering to answer a specific health question. And clinical trials are devised so that we can investigate new ways to prevent, detect, or treat disease. From an oncology standpoint, I would say the overwhelming number of clinical trials are designed to be able to advance treatment better than the current standard of care treatments that are available. And we're trying to determine if the treatments work, meaning are they effective, and importantly, are they safe? In regards to some important clinical trial terminology, I wanted to review some key terms. So what is a protocol? So protocol refers to the action plan that describes what is going to be done in the context of that study or clinical trial. And it's going to explain in detail all the different parts of that study. So every clinical trial must have a protocol document. And usually this is a document that is on average about 100 pages in length that a principal investigator or PI spends a lot of time writing and developing. And so within this protocol document, it's going to include a lot of details, including who is eligible to participate in the clinical trial. It's going to explain the treatment plan, what the drug is or treatment is, the safety information related to that drug or treatment, details about the tests, like is this trial going to involve blood work and MRI scans or any other unique procedures or tests. The protocol is also going to document and clarify, on this trial, patients are allowed to continue taking these certain medications or not able to continue. So it's going to give a lot of details so that anybody who is allowed to enroll patients in a clinical trial has a very clear understanding how the trial should be conducted. It's also going to document and clarify the length of the study. Is this a treatment that patients will do for 6 months or 12 months or longer? And what information is being collected? So beyond maybe the blood work that's collected in terms of the lab results, is there MRI information, or there's going to be other information collected from the patients and perhaps even their caregivers? Every clinical trial must be reviewed and approved by what we call an IRB, which stands for an Institutional Review Board. So every institution has one, and this is a special board of individuals who very carefully review any protocol that's submitted to ensure that the protocol is being done in a safe way and for the benefit of patients. And so there is this regulatory body that helps ensure that everything is being done to a certain standard, which is a very high standard. What is informed consent? So that's another buzzword in terms of the consent document. So this just describes the process in which potential patients or participants are given key information about the clinical trial before they decide to participate. So informed consent is usually something done with a research nurse, study coordinator, your treating physician. They are all going to walk you through information about the clinical trial, so you can be as fully informed as possible to know if it is something you would want to move forward with or not. Participation in any clinical trial is voluntary, and I can't underscore that enough. Even if you were to start on a clinical trial and for some reason you want to withdraw participating, you can do that at any time. You are never obligated to finish a trial or obligated to participate even at the outset if a clinical trial is presented to you. The informed consent document explains the details of the study, potential risks and benefits, as well as your rights and responsibilities. So the informed consent document will give you information about, as part of this clinical trial, you will be asked to do blood work every 4 weeks or have an MRI at certain intervals. So it's going to walk you through all the commitments that would be asked for you on your part if you were to participate. Members of the research team will discuss the study with you at length and answer your questions so that you can make as informed decision as possible about whether or not you want to participate. Whenever I'm talking to my patients in clinic about a clinical trial, I always advocate for taking the informed consent document home and at least thinking about it in the evening. There's no rush to necessarily make a decision within the context of a clinic visit. I really want to make sure that my patients really have time to think things over, ask the right questions, discuss with their family before necessarily committing to participate. So who can participate in a clinical trial? So all clinical trials have guidelines about who is eligible. So some of these factors may be related to age, it may be related to the type of disease, maybe related to the type of brain tumor diagnosis that someone has. Their medical history, meaning do they have certain medical conditions in the past that might even be ongoing and active that might make it a limitation for them to participate in a specific clinical trial. What is their current functional performance status, which we'll talk a little bit more in detail about. So factors that allow you to participate in a study are called inclusion criteria, and factors that prevent you from being able to participate are referred to as exclusion criteria. In neuro-oncology, we typically use something called the Karnofsky performance status, which we call KPS for short. And this refers to a performance status scale to give us a kind of a bird's eye view of how someone is doing at any given point in time. Now, in oncology in general, there are other similar scales. Some folks may have heard of something called ECOG, which is a type of scale that also measures how someone is performing or functionally doing. But in neuro-oncology, we tend to prefer to use KPS. So even outside the context of a clinical trial, us at MD Anderson routinely document someone's KPS because it allows us to have a sense from visit to visit or time point to time point how someone is doing. So for instance, here is the scale. And what you'll see is 100 KPS means that someone is doing excellent. They have no outward evidence of disease. They have no complaints in regards to symptom burden. If you didn't know otherwise, you would think that there was nothing different about them. You wouldn't know that they necessarily had a specific diagnosis. Then as the scale goes down in number, you'll see that that reflects that someone is having a little bit more symptom burden or having outward signs of having manifestations of their, let's say, tumor diagnosis or cancer diagnosis. So I highlight this green box to show that in general, clinical trials typically require a Karnofsky performance status of 70 and above. So 70 means that you're able to care for yourself, but you might not be able to still hold the same job that you did before. And you might not be able to do as many household things, or there's some clear limitations on what you're able to do compared to prior to your diagnosis. Now, some clinical trials will allow for KPS as low as 60, which means that you might need assistance with, let's say, dressing, but otherwise you are otherwise doing okay. And so there is sometimes some flexibility depending on how the clinical trial is written. And so one might ask, well, why do we even have a criteria for functional status? And why can't someone who's doing not as well still be offered a clinical trial? And I think the point to emphasize here is that safety is the biggest priority for a number of clinical trials. If we take someone with a KPS of 40, meaning they're disabled, requiring special care and assistance, this could be someone, let's say, in the hospital who's very sick and not safe to be discharged home. If you take a person who's already having difficulty on a day-to-day basis and you expose them to a new treatment that is investigational that we're still technically learning about, we might actually cause more harm. And that's definitely something that would be absolutely against what our intention is in terms of trying to be able to help our patients. So the reason we have these parameters is so that we can deliver the treatment to the group of folks that are less likely to be hurt by any kind of new treatment. And so that performance status needs to be ideally as high as possible, so that patient has the most likely opportunity to benefit and not be harmed by any kind of side effects from the treatment. In regards to preclinical research, I think we have to kind of understand, where does a clinical trial originate from? So I'd like to segue into talking about the different phases of clinical trials. So before an investigational treatment even gets to the point of being studied in patients, there's a lot of work that is led up to it. So some folks may recognize the gentleman on the right, that's Dr. Jim Allison. He is faculty at MD Anderson, and he did pioneering work in the field of immunotherapy to help basically develop new types of immunotherapy and specifically checkpoint inhibitor drugs, which have completely revolutionized the care of cancer patients. Many of you have probably seen commercials on TV for Keytruda or Opdivo. This is all as a stemming from Dr. Allison's pioneering work, and he was awarded the Nobel Prize for everything that he has done. And so folks like Dr. Allison and many other folks are working really hard in the lab to be able to think about, what would be a strategy to form a foundation or a basis to develop new treatments from. So in the lab, a new treatment can be administered initially to animal models. So there's certain criteria to be able to get to the point where we can give these treatments to patients safely. So oftentimes there's some cell line work, which refers to we're actually just kind of testing things like in a petri dish, more or less. And then oftentimes there's an animal model, again, just trying to graduate on improving those safety evaluations on whether or not a treatment can get to the point of getting to a clinical trial and being available for patients. So in the lab, meaning that if there's all these safety evaluations done in these different stages, if there's a suggestion that this might be effective, then the sponsor of the clinical trial, and this could be like a PI like myself, or this could be actually a pharmaceutical company, they basically have to apply to the FDA to submit an IND, which is an investigational new drug application. And this is basically asking the FDA for permission to study their treatment in patients in the context of a clinical trial. As a PI, I've submitted a number of IND applications. It is an extraordinarily lengthy process. It sometimes takes up to 1 to 3 years to get the approvals to be able to even start a clinical trial. But this just underscores how much regulation there is in terms of by the FDA to make sure that anything that folks are developing to do clinical trials is really highly regulated and really looked after, again, with the primary goal of keeping patients safe. So oftentimes when folks are talking to you about clinical trials, you may hear them reference phase 1, phase 2, phase 3. And I wanted to go into a little bit more detail about what those words actually mean in regards to those phases. So phase 1 refers to looking at primarily safety. So in phase 1, the overarching goal is to show that a new drug or treatment is safe. During this phase, doctors are going to be collecting data on the dose, timing, and safety of the treatment. So when someone is participating in a phase 1 clinical trial, they are often the first patients to even be exposed to a new treatment or combination of treatments. And oftentimes in a phase 1 trial, the dose of the drug is gradually increased, sometimes 2 times, sometimes 3 times, so that we can find that sweet spot of the drug being safe and not causing too many side effects. Because oftentimes we can predict what side effects may happen, but we never actually know until we're actually in phase 1 and looking at the drug in patients themselves. So during phase 1, doctors may also collect information about how the drug is absorbed, processed, or spread throughout the body. So it's not unusual that during phase 1, if you're participating in a trial in this stage, that you'll have a lot of blood tests done. And the reason that we're doing that is we're trying to monitor that drug in your bloodstream and see how it's broken down and see if it's reliably following what we think is going to happen. Oftentimes in phase 1 trials, because the goal is safety, the number of patients that are involved is small. It's typically maybe 10 to 20 on average. And I think one important thing to keep in mind is that all currently available treatments, every single prescription drug that is out there, and also over-the-counter drugs, at some point they were in a phase 1. And that required patients to volunteer or folks to volunteer to be part of that study. So everything started off with a phase 1 trial. So phase 1 is done. So what we've done is we've proven that the drug can be given safely to patients. And there's no new safety signals. And now we're trying to take the next step. And we know the dose from phase 1. So we've taken the information we've learned in terms of what is the sweet spot for the dose to give to patients in a larger number. And so in phase 2, we're going to start gathering more information about not only in addition to the safety, but now we're going to start to see how well it works, which is what we call efficacy. So this is what people traditionally think of as clinical trials, is the efficacy, right? Because we want to be able to show that this treatment works. And ideally down the line, we want to prove that it works better than the standard of care. So a phase 2 clinical trial focuses on whether a new treatment works. A response, particularly in oncology, is typically measured in different ways. With oncology, oftentimes we're focused on a tumor. And so we want to see, is a tumor at least staying stable in size or possibly decreasing? And that would be a sign to us that the treatment is working or not working. Phase 2 clinical trials typically involve a larger number of patients. So in comparison to phase 1, where it's a small group, this is now a little bit of a larger group, on average 20 to 50 patients. And this is in the context specifically of brain tumors. Certainly in other aspects of medicine, phase 2 and phase 3 trials are much larger, but because brain tumors in general are rare, these are the average numbers in terms of what we'd expect in these different phases of the trial. Now, sometimes in a phase 2 clinical trial, patients may be assigned to several possible treatment arms. So they might get randomized to get one type of treatment versus the other. So after phase 2, if there's a sign that there's continued evidence that it's safe, and now we've actually shown that there is an efficacy signal, meaning that patients did well on the trial or they had response in their tumor, that is how a trial could then transition to phase 3. And so we're taking that new treatment that has shown some promising results, and now we're going to study it in even a larger group of patients to see if maybe it can surpass or be better than the current standard of care for whatever that specific disease is. And so now we're going to collect data from a larger group of patients and again, compare it to standard of care to prove if our theory or what we saw in phase 2 is going to hold true in a larger number of patients, typically on the order of hundreds. Now, phase 3 clinical trials typically are randomized because we want to be able to compare the new treatment to the current standard of care to really show that there's a difference, and ideally to show that the new treatment is better than what we currently have to offer. So this is just a brief table to kind of summarize what I explained in regards to what we're trying to accomplish in the different phases of clinical trials. So again, in phase 1, we're evaluating safety, identifying side effects, small number of patients. Phase 2, continuing to evaluate safety, but now we're starting to look to see, does the treatment work well? So determining effectiveness, larger number of patients. Phase 3, continuing to monitor safety as always, monitoring side effects, confirm effectiveness. Because sometimes in a smaller sample size, there might be some evidence that looks like something's working, and then you take several hundred folks and we can't reproduce that. And that has certainly happened in the development of treatments for brain tumors, where sometimes there was a positive phase 2 trial, but then when we got to phase 3, it was negative because it wasn't reproducible in a larger number of patients. And often phase 3 clinical trials require comparing to standard of care or some kind of equivalent treatment. So phase 4 you usually don't hear about, but this is happening behind the scenes. So after a drug is approved by the FDA and made available to public, meaning that your doctor can just write for it without having to put you on a clinical trial, they have ready access to it. Drugs are continually monitored by the FDA to ensure that there's no long-term side effects or anything unexpected in association with that drug. Researchers also continue to track safety information so they can continue to learn as much as possible about the drug risks and benefits, and we watch those long-term effects of the treatment. So to kind of summarize the key terms that you might hear in association with clinical trials, I just wanted to highlight some that have been briefly mentioned, but just to focus on these terms more specifically. So placebo. So placebo refers to an inactive product that resembles a study drug, but doesn't have any of the treatment value. So sometimes folks will refer to this as the sugar pill. I'll have to say that in oncology, we tend to not do placebo-controlled trials, and particularly in neuro-oncology, we do not tend to do placebo-controlled trials. We always want to ensure that our patients are getting some active treatment, especially because of the nature of the tumors that we treat. Randomization refers to the process in which 2 or more alternate treatments are assigned to the patient volunteers by chance rather than choice. So it's not that your doctor chooses which treatment arm that you go into, it's by chance. It's almost like flipping a coin, but it's basically done by a computer. That's what randomization is. So sometimes it can be randomization to 2 different arms or 3 or 4. It all depends on how that clinical trial is written. So blinded studies. So in general, these are less frequently seen in regards to neuro-oncology, but on occasion, there might be a blinded study. So single blind study means that the patient volunteers do not know what is being administered, but the research team knows. So there's usually 2 arms, and they might not know if they're getting, treatment A or treatment B. This helps reduce some of the bias or interpretation of if the treatment is working or not. Double blind means that the patient volunteers and the research team do not know what is being administered. Again, the goal of a trial in this design would be to reduce any kind of bias from either the patients or the provider team that is taking care of the patient. Inclusion criteria we had talked about briefly, or the factors that allow a patient volunteer to participate. Exclusion criteria are the factors that would exclude you from participating. So these factors can be anywhere from age. So there's a lot of clinical trials that are strictly for adults. And so, of course, we classify adults as 18 or older. And that has definitely been a point of controversy because we have a lot of pediatric age patients, particularly in their teen years, that often may have a tumor that biologically behaves the same as an adult. And so there's a lot of conversation within the neuro-oncology community about, are these strict age criteria really appropriate? And maybe we should extend that in terms of inappropriate scenarios. And we'll talk a little bit more about that in the future slide. Stage or grade of disease. So for certain clinical trials, you may have to have a glioblastoma diagnosis versus like a low-grade glioma diagnosis. These are types of brain tumors. So there'll be very specific criteria about what diagnosis is required to be able to participate in that clinical trial. Treatment history. So you'll often maybe hear about, if you've had a certain treatment in the past, it might limit your ability to participate in a future clinical trial if you've already had certain types of, let's say, radiation or drugs such as Avastin. That might limit your ability to receive, let's say, the clinical trial treatment. Other medical conditions and diagnoses. So for example, a lot of the immunotherapy clinical trials typically exclude folks who already have issues with an autoimmune disease. And the reason is that immunotherapy treatment could maybe aggravate someone's underlying autoimmune disease. And so sometimes that might be a limiting factor about why or why not you can participate. Sometimes patients have more than one cancer diagnosis. And so clinical trials always have criteria about if someone has an active second cancer, it might not be safe to give them this clinical trial treatment for, let's say, the brain tumor. So these are all different things that will be detailed in the protocol. And we talked a little bit earlier about the performance status, which refers to how well is someone doing, how independent are they, and how able are they to care for themselves. So how do you decide to participate in a clinical trial? You've been offered one by your study team and you're trying to think through, the pros and the cons. I wanted to split this up into potential benefits and then potential considerations that you might want to think very carefully about. So in regards to the benefits, you might be gaining access to a new treatment that's not available to the public. So it's kind of a point to say that, a lot of folks, particularly with brain tumors, are looking for something above and beyond standard of care. And so a clinical trial allows you the opportunity to gain access to a new treatment that is not necessarily readily available to a community oncologist because they don't have access to it. It's not approved yet. It's still being studied. You will get expert medical care at a leading healthcare facility in the clinical trial. So clinical trials typically have to be done at academic institutions. It's very hard for a clinical trial to be done out in, let's say, a private oncologist office because they don't have the bandwidth or the personnel to be able to oversee the conduct of the clinical trial. So clinical trials typically mean that you're being treated usually at a university hospital or a place like MD Anderson Cancer Center. When you are on a clinical trial, your research team is basically additional folks that are caring very much about you, and they're an extension of your current medical team. And so you're going to have additional assessments, and there's just going to be more folks that are looking out for you. During your visits with phone calls, they're going to be checking on you much more regularly than if you were just doing routine treatment where you would only see your typical medical team. And I think there's a really important aspect about the altruistic component, that you're helping others by contributing to medical research. And I can't tell you enough that in my 10 years being a neuro-oncologist, that sometimes when someone's newly diagnosed with a brain tumor, I will often hear the sentiment of, if I can do anything to help someone else with this diagnosis down the line, that's something I wanted to do. And I want that to be part of my legacy. And so I think that's a very important point that strikes home with a lot of folks in terms of, all clinical trials require volunteers. And so a lot of folks look at clinical trial participation through that lens, that they're hopeful that it's going to help them, but also that it might help someone else. Potential considerations. So there might be side effects from the treatment. And this is important because for current approved therapies, we are very well versed in the side effects that should be expected. Now, sometimes with investigational treatments, we may be able to predict what the typical side effects, but sometimes unusual things may happen. So that is a potential consideration of that. If you're someone who feels anxious or nervous about really rare side effects or unique side effects, so there's anything that makes you feel uncomfortable, that's something to be very thoughtful about. The treatment may not work. So again, we are hopeful that all these new treatments are going to be better than what we currently have to offer, but there's also a chance that it may not be as good. And the only way we know is if we try. So that is definitely a consideration to take into account. The clinical trial may require more time from you and trips to the study site. So typically a clinical trial is more intensive in regards to appointments and commitments that are being asked of you to participate. In comparison to if you're receiving standard of care, you don't have to come to the study site probably as often. And the new treatment may not be available right away after you finish the clinical trial. So usually clinical trials have a specific time frame in which you have for the study, and then you complete the study, and sometimes you may not be able to necessarily continue the study drug. You might have to come off of it. And so that can be potentially looked at as a consideration and something important to understand and ask your team about, so that you really kind of have a full sense of what may happen if everything goes well and you graduate from the clinical trial. What does that look like on the other end of it? So questions to ask your doctor. So I kind of summarize these a little bit, but if I was in the shoes as a caregiver, as a patient, these are the things that I would be thinking about asking my doctor if they're talking to me about a clinical trial. So what's the purpose of the study? So this is where you should understand, what phase are they in? Is this to primarily study the safety, phase 1, or are we actually now at phase 2 or beyond to look at how effective it is? Why do the doctors and researchers think it'll work? Like, what's the mechanism in which we think that this is something that we should put our hope in? What will be my responsibilities if I participate? Does this mean I have to come to clinic every 2 weeks, or is it every 4 weeks? Will I have to have extra MRIs? How often do I have to have blood work? These are all things that will be readily discussed, but things you should also ask if they're not outright stated. What are the potential side effects? What other options do I have? So if I don't do this clinical trial, are there other treatment options that I'm a candidate for? Really understanding the breadth of all your options at a time point where a decision has to be made is so important. And doctors usually will be very outright in terms of kind of giving you the different options and which ones are possible and which ones maybe are not possible. What kinds of procedures and tests will I have? Will it be a clinical trial where I actually have to undergo another surgery again? Is it a clinical trial where I have to undergo a lumbar puncture or spinal tap? These are all things that will be discussed. Can I take my regular medications? And in conjunction medications, how about the supplements that I take? I'm used to taking this whole list of medications. Are all of these things going to be okay for me to take with the study treatment? How long will I be on the clinical trial? Is this something that I'm on for a couple months or maybe a year or longer? And so these are all things to think about to ask your doctor. So after a clinical trial is complete, the researchers examine the information that's collected, and then the results are published in a peer-reviewed scientific journal. And usually if a drug gets to the point where it's successful in phase 3, then the journal article comes out, and typically FDA approval comes out, and then that drug becomes much more widely available to doctors for them to write for it. And so I commented on this earlier in terms of that altruistic component, that oftentimes patients want to volunteer for a clinical trial because there's hope that it will benefit them, but that also they can help others. And so participating in a clinical trial does make a difference, because it's only through research can we gain knowledge about answers about the safety and effectiveness of drugs and therapies. And none of this would be possible if we didn't have patients who volunteered to participate. So we're going to segue and transition to just a different part of the presentation to talk a little bit about the barriers to clinical trial enrollment and how do we improve access. So we have hopefully a foundational understanding about the different phases of a clinical trial as well as the key terms, but I'd like to talk a little bit about the challenges that we definitely see and how we can improve upon them. So we've actually looked at clinical trial participation in the oncology world and as well as in the neuro-oncology space. So it's interesting to see that there's actually only a small percentage of patients who participate in a clinical trial that have cancer. And it's only even a smaller percentage that participate with brain tumors. And so why is that? And it's really complex, and it's multiple reasons. And so in summary, we know that lack of awareness of available clinical trials definitely plays a role. So depending on where your primary treatment is at, for instance, if you're primarily out in the community, you're perhaps not going to have as much awareness about what MD Anderson Cancer Center is doing, because you're not being routinely followed in a place where clinical trials are part of the day in and day out care of patients. Sometimes there's misconceptions about research participation. I have had many patients tell me very honestly and transparently that they don't want to be a guinea pig. So they perceive that clinical research is very experimental, and that maybe to some extent they feel like they're just being used to be able to further research, but they might not see the direct benefit that they may gain from being able to be on a clinical trial. A study burden, including cost and travel constraints, is huge. So at MD Anderson, 75% of our patients come from outside 150-mile radius. So most of our patients are absolutely not local Houstonians. Most of my patients are traveling several hours by car, by flight, and I actually have a fair number of international patients. So asking someone to participate in a clinical trial that, let's say, requires them to come every 2 weeks, that might not be feasible for someone who, let's say, lives in Florida. And so those are things that we definitely recognize is an enrollment barrier. There's numerous disease and demographic barriers, which we'll talk through. And we also looked at, perhaps as providers who write these clinical trials as PIs, maybe our trial eligibility criteria is too restrictive, and we narrow that scope of patients that can participate too much. And so how can we loosen that without compromising the safety of patients, but maybe make the enrollment a little bit more successful and make these clinical trials more available to patients? So when we've actually looked at a number of studies in terms of clinical trial participation in neuro-oncology, we saw that patients who are eligible but tended not to enroll usually were older, with poor performance status, and lived further away from the treatment center. And so these are things that are truthfully not surprising, because we recognize that logistically, if it's hard to get to the study site, it's going to be a barrier to be able to participate. If you're not feeling as well, or if you have a harder time getting around, it's going to be harder to participate. And when you're older, same things. Those are the barriers of, related to getting to the study site, or maybe not feeling as good, or not maybe being as mobile. They've also observed that education level was associated with enrollment, with college-educated patients being a little bit more likely to participate in others. And lower income was also associated with less participation in clinical trials. And some of these demographic factors are very complex and multifactorial in terms of what these exactly represent. But to some extent, I think we realize that certainly all these factors that play into how accessible the clinical trial is so important. And this helps inform us as providers and folks who write clinical trials that these are things that we should be sensitive to and address to see how we can potentially overcome the barrier for any one patient. I mentioned earlier that sometimes the eligibility criteria are often too restrictive. You know, a lot of clinical trials, when we write them, we do a lot of copy forward in terms of the clinical trial eligibility criteria. You know, we continually say age over 18, but have we thought about that really thoroughly in terms of maybe for that treatment, if that is a treatment in a patient population that tends to be young adults, maybe we should lower that threshold to 15, you know, in terms of we don't want to keep copy pasting forward, because eligibility criteria that's too restrictive is going to slow down your accrual. It's going to restrict the access for patients to be able to participate. And it reduces the chance of knowing how the drugs really work in the real world, right? The real world is not some kind of isolated silo of a very specific group of patients. The real world means that, you know, the treatments can be much more available to a larger group of patients. So ASCO is the American Society for Clinical Oncology and the Friends of Cancer Research. These were two organizations that got together to help try to optimize oncology clinical trial eligibility. And they specifically looked at 5 areas to be able to have some more flexibility in regards to, for a lot of clinical trials for oncology patients with other types of cancers with brain metastases, a lot of patients who've had brain cancer spread from their original site of cancer, oftentimes they're excluded. And that feels really unfair that if this wasn't for the brain metastases, they would have otherwise been eligible. The minimum age, which I referred to briefly, concurrent HIV infection, organ dysfunction. So sometimes folks have other reasons why their kidney or liver function is not perfect. And oftentimes these clinical trials are just copy forwarded, meaning you have to have perfect liver and kidney function to participate. But let's say the treatment doesn't have any potential negative side effect to kidney function. So that patient really be excluded. And so these are all the things that we should really give some thought about. The prior and concurrent malignancies. This one's a tricky one because I have run into this as a barrier, is that sometimes someone has had prostate cancer within 5 years or within 3 years. And depending on how the clinical trial is written, sometimes those patients are excluded simply because of their prostate cancer diagnosis, even though that from that disease status standpoint, it's not active and they're doing really well. But if the language is too restrictive and doesn't allow for some nuance, that can potentially prevent that patient from participating. Now, this is a very busy slide, the next 2 slides, but I just wanted to show you that there's a lot of ongoing work in the neuro-oncology community to specifically look at the criteria that might be too restrictive. And maybe we should loosen the criteria. Again, not to compromise safety, but for us to make clinical trials more accessible to more patients. So looking at lowering the age, maybe looking at lowering the functional status a bit. Allowing patients with a prior cancer diagnosis, if they are doing well from that cancer diagnosis, to be allowed to participate. You know, a lot of times clinical trials require that it's been, you know, X amount of time since your last treatment before you're eligible to participate. And then during that time, when your tumor is growing back, you're just sitting there waiting. And so is that really rational? Maybe we should say 5 drug half-lives. So we know the prior treatment is completely washed out, and maybe it's shorter than 4 weeks, and let's get you on the new treatment. There's other things like tissue requirements that sometimes can be restricted. Oftentimes with lab values, as I mentioned before, like sometimes our demand to have perfect liver and kidney function or other labs might not be reasonable, especially if there's not an expectation that that treatment's going to negatively affect your lab work. You know, the diagnoses, you know, in terms of how we classify tumors has evolved so much over the last several years. And sometimes, again, if the criteria is too restrictive, it doesn't allow the trial to potentially benefit as many patients as possible. So how do we improve access? So we recognize that geographic access could be a huge hurdle. I mentioned even at MD Anderson for our, you know, the routine care patients, most of our patients don't live in Houston. We're dealing with folks that are driving or commuting a significant distance, including oftentimes plane rides. Sorry. Possible ways to improve participation. So maybe we can do some of the routine clinical trial assessments, such as blood work, outside of the study site. Have external labs done at LabCorp or Quest. That saves you at least 1 or 2 or even more trips to the study site. Virtual medicine. So this became something that has become such a mainstream part of our care of patients, and it really was prompted by COVID. We had to think outside the box and recognize that people aren't going to be able to come on campus as easily, because at that point we were trying to socially distance and so forth. And so telemedicine visits can sometimes replace some of the in-person clinical assessments where appropriate. And so that can maybe help reduce some of the barriers in having to come to the study site so often, and allow some of the administration of treatments to be given in the community. Maybe there's a way for us to partner with community sites so that the infusion or the drug or the new treatment can be given a little bit closer to home for that patient. So we know that income disparities has certainly limited access to clinical trials for some patients. And so this is something that is complicated, but it's something we want to be mindful of. So we've actually done research looking at clinical trial participation and looking at the relationship between that and household incomes. And there was an observation that for household incomes less than $50,000 a year, those patients were less likely to participate. And we've talked about just how financially burdensome sometimes clinical trial participation can be. And so maybe there's an opportunity for incentives or reimbursements, like for gas or for the hotel stay if they need to stay overnight, that could be appropriate. But again, being very careful to make sure these wouldn't be coercive to patients to participate, but being mindful of a patient's unique situation and seeing how we can overcome their individual hurdle. Considerations with respect from time off work, childcare, transportation may also help improve access for clinical trials for patients who have lower income. I try to make an effort to fully understand everything on my patients in terms of, do they have young children? Do they have a job they're simultaneously trying to navigate? Is their primary caregiver also working? Are they work from home? Or do they be on site? Like, what are the potential barriers that might be there for them to have care or even participate in a clinical trial? Because the more we explore as providers, the better we understand how to help our patients. Collaboration among academic and community centers. So I mentioned that maybe there's an opportunity for some of the study treatments to be done closer to home, whatever that community is for that patient. And I think it's so important for us providers to really pay very close attention, listen intently, and just be mindful of all the different things that we need to pay attention to. I think one of the things that oncologists in general get very bogged down in clinic visits with patients is they get stuck in the biomedical. And by that, I mean, oftentimes they're so focused on the labs, they're so focused on what the scan shows, and if you're clear to do your next cycle of treatment, but they may not be spending as much time talking to you about your symptom burden. Are you having fatigue? And if it's a yes, like, explore what that means, because fatigue is so different, right? Is it fatigue that's limiting the things that you want to do? If it is, like, let's talk about that. Know your patient's education background. Where are they coming from? In terms of what are their perceptions about clinical trials? I always ask my patients if it's an opportunity to be able to introduce a clinical trial to them. Have you heard of clinical trials? Tell me what you know about them. Have you ever known someone to participate in a clinical trial? I had a patient whose husband actually was an MD Anderson patient with lung cancer, and he had participated in a clinical trial, and he actually had a very bad outcome in terms of he got very sick. And so that made her very fearful for herself to participate in a clinical trial because of her prior experience. And fortunately, I knew that because I asked all those questions, so I knew where she was coming from. And that helped shape my discussion to be able to help try to alleviate concerns, address her concerns, and then kind of walk her through if this would be a good fit for her. But knowing where someone is coming from is so important, so that can then guide the conversation. And this is really something that providers should do, and I hope that they do, but something that I think would be tremendously helpful for patients. Employment status is important. So are they trying to navigate a work from home situation, or maybe they have to go on site for their job? How intensive is their job? Do they have to travel for it? Are these going to be things that are going to be potentially barriers? Maybe they have to work certain days of the week and they're only be going to come for appointments on Fridays. Being able to say outright, like, we're going to work with you so that we get everything done on Fridays so that you can navigate and manage, being able to keep your job and still be able to participate. The more that we as providers say that outright, it's going to help reduce some of those barriers. Explore factors that influence trial enrollment in minority populations. There's been a lot of work done in terms of kind of looking at some of the discrepancies in minorities in terms of participation. And again, understanding where folks are coming from, what their perceptions are, so we can try to meet in the middle and make sure they're informed and encourage them to participate if it's something that's consistent with their wishes. And of course, we are full on in the era of social media. And so social media can be a wonderful tool to help disseminate information about clinical trials. I mean, you can spread it so much further than before social media was ever around. And so it can certainly be an advantageous tool. And there was previously a workshop led by the NIH where they actually did a whole workshop on clinical trials and social media and just trying to use this platform to be able to help spread the word about clinical trials. And improving access in regards to other organizations that are really heavily involved in trying to make things more accessible for patients and caregivers. Society of Neuro-Oncology, SNO. There's the RANO group, patient advocacy groups, clinical trial cooperative groups. Everyone has a unified mission to make clinical trials more accessible for our patients. And clearly, it's not a one answer that's going to resolve the issue. It's very complex. But I think our increasing awareness over the years about the barriers is going to help us understand how to help our patients and caregivers. And lastly, what can patients do? What can patients and caregivers do to help advocate for themselves? So what I would recommend is ask your doctor or provider team about clinical trial options. Or perhaps if you're out in the community, ask about a possible referral to a site that offers clinical trials. You know, MD Anderson has on its website a referral form. So as a patient, you can actually fill out their referral form and seek out an appointment at MD Anderson. And that's similar to Duke and UCSF. A lot of big academic institutions with a lot of neuro-oncology research have mechanisms for you to be able to come as a new patient and to explore your treatment options beyond what may be offered to you locally in the community. Be honest about your potential barriers that you might have. This is where you really want to be transparent, because if you tell your provider team, I really want to participate, but these are my concerns or these are my individual barriers, whether it's travel, it's financial, there may be a workaround, but your provider team may not know unless you speak up. Because sometimes there are opportunities for reimbursement for gas or hotel stay, but unless you actually share that with your providers, that is a concern for you or a barrier, they won't necessarily know to be able to offer that to you. So please just be honest so that you can work together with your provider team to make it possible to participate in a clinical trial. For folks that are looking for clinical trial options, the clinicaltrials.gov website is a registry and database, privately and publicly funded. And it basically is like this huge database that describes all of the clinical trials that are open. It gives information about eligibility criteria, the sites in which that clinical trial is open, as well as information about who to contact if you're interested. So it's a tremendous resource. So that's something that's within your control to be able to reference and help advocate for yourself if you're at a time point in your treatment or your disease where you have to look at some treatment options beyond what you're currently on. And thank you so much for your attention. I'm happy to field questions.
Thank you so much, Dr. Weathers, for that wonderful presentation. Just as a reminder, if you have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. Dr. Weathers, you talked about the low participation rate of brain tumor patients in clinical trials, and you highlighted that the restrictive inclusion criteria may be a factor. This question is asking, what happens to patients who don't fit within those inclusion criteria for a clinical trial but may benefit? Can patients get special access to these trials through something like compassionate use? And this person who's asking the question has unfortunately been ineligible for many trials due to their age. So they're coming from that age lens of inclusion criteria.
Yeah, no, fantastic question. So the answer is sometimes yes. Not always yes in terms of a workaround. So we've actually had scenarios where, MD Anderson being the type of academic institution that it is, a lot of pharmaceutical companies will come to us wanting us to help run their clinical trials. And sometimes because of the eligibility criteria, it's a very narrow scope of patients that the treatment is actually eligible for. And so there are opportunities for what we call single patient INDs, where sometimes it's often referred to as like a compassionate use. So sometimes if a patient doesn't meet the restrictive criteria, but we as the treating team really feel that that patient could benefit, there is sometimes an opportunity to apply to get a patient a specific treatment because we feel strongly that they could still benefit. And I've actually done that for a number of my patients who, met that criteria in terms of they couldn't officially get on the clinical trial for whatever reason, but I felt strongly that they would benefit from the treatment. And we at MD Anderson, because we're well versed at that, have been successful in securing different drugs for patients. So sometimes it's a possibility. It all depends on that particular patient and a number of other factors. But I say that to say that sometimes outside a typical clinical trial, there may still be an opportunity or route to have access to the study drug.
Thank you so much for sharing that insight. Another question we have here is asking, do you have to have health insurance to participate in a clinical trial?
So that's a great question. So in general, yes. So clinical trials, typically in regards to, I mentioned the expense in regards to the number of studies. So usually when folks have a health insurance plan, there is a clinical trial benefit portion of that insurance coverage. And so anytime that we are considering a patient for a clinical trial, the first step we have to do is actually secure insurance approval. Because sometimes insurance companies will allow you, for instance, to get care at MD Anderson, but may not cover participation in a clinical trial. So those are things that we help sort out for you from a logistics standpoint. But in general, clinical trials typically do require insurance coverage. Now, I have had situations where patients are uninsured, but then through the institution they're being treated at, like MD Anderson, we have financial assistance programs. So at MD Anderson, we actually have something called PFA, or Patient Financial Assistance, and there's an application that you can fill out. And if you get approved for financial assistance, everything is covered. And so there is still an opportunity for folks who are uninsured to still potentially have access to a clinical trial if they're approved, for instance, at MD Anderson for a financial assistance program. And so that's where being transparent with your provider team about what your individual hurdle may be is so important. So for instance, I have a lot of folks who don't have health insurance. They'll come see me for a visit that they had to pay for out of pocket. And then we're trying to navigate. And then I know that's where they're at. They're a self-pay patient. And then we try to figure out ways for them to still have access to care beyond that initial visit.
Thank you so much. And a follow-up question to that, for financial assistance programs like the one you're describing at MD Anderson, are those only available to patients currently being treated at that treatment center, or could a patient that's looking into a trial at MD Anderson, for example, be eligible for those types of financial assistance programs?
That's a great question. So it typically means at least one visit. So at least kind of getting your foot in the door so you become an established MD Anderson patient. To become established, it just takes at least a one-time visit so that you can work with our social workers and our financial clearance center to fill out the application that then is then reviewed by a certain group at MD Anderson to see if we can continue your care. So it's not something that can be kind of started from scratch if you've never technically been seen at MD Anderson. But if you've taken that initial step to be at MD Anderson, then there's an opportunity maybe for you to be able to continue if we can get the financial assistance set up for you.
Thank you so much. We have another question here asking, more generally, how can patients get information about a clinical trial? Is it their neuro-oncologist's responsibility to share what trials they may be eligible for, or are patients and caregivers really kind of having to advocate for themselves and do that research themselves?
So in ideal case scenario, I think it should be the former. I really think it should be your provider team walking you through what your treatment options are when you're at those certain crossroads, like when you're maybe you're first diagnosed or if the tumor is growing back. So at MD Anderson, we're going to be really well versed in the clinical trials that we have at our site. We may have some general awareness about what's going on at different sites, but we're going to be really well versed in our clinical trials. I have a lot of patients that do a lot of things on their own. With the internet, it's so easy to search things, or sometimes there's even these navigator services where sometimes they will help identify clinical trials. But I really like to think that it's the providers that are walking you through what your treatment options may be. But it never hurts to also advocate for yourself and explore your options. Or if you're being treated out in the community, to even make that one-time visit to an academic site where you can be able to explore your options that maybe your local provider is not aware of, and not to their fault. They just literally might not be aware of. Just like I can't know everything that's open at Memorial Sloan Kettering Cancer Center, just like I wouldn't expect them to know everything at MD Anderson. But at least trying to, if you have the ability to be able to sometimes get that second opinion, I think that's really valuable in terms of just making sure you understand all your treatment options.
Thank you so much. And you did share clinicaltrials.gov as a great resource to look up studies. Are there any other databases like this that you're aware of? Sometimes clinicaltrials.gov can be difficult to navigate. Are you aware of other resources that can provide more lay-friendly information on trials?
Yeah, absolutely. So I know different organizations for brain tumors will have their kind of their own individual trial page. I know like even ABTA, there's like general trial information about understanding clinical trials. But if you're looking for something specific, for instance, MD Anderson has their own clinical trial page, and we try to make it pretty friendly and easy to navigate. So it isn't so hard like the clinicaltrials.gov page, which is a lot of text and no pictures and not a lot of color. So I would say sometimes if you're trying to do a search, you could do things like MD Anderson glioblastoma clinical trial, and that should populate our webpage with the different clinical trials that we have available. Same thing if you were to do that for Duke or for Northwestern, you should be able to search those terms specifically if you wanted more detailed information about what an individual study site might be doing in terms of clinical trials they're running.
Thank you so much for sharing those resources. Now, you talked about the different phases of clinical trials. Is there a standard time frame that a clinical trial is within each of these phases? Is that a moving target? And can you maybe provide a general guideline or estimate of how long it takes a clinical trial to move through these different phases?
That's a really fantastic question. It's very dynamic. So depending on the eligibility criteria, and if there's like certain periods where you have to enroll a certain amount of patients and wait to evaluate safety, there's all these things that can contribute to lengthening the time of a clinical trial. But in general, it takes years. And on average, the time from kind of drug development to FDA approval, it's about a 10-year cycle. So it's an extraordinarily long process, and clinical trials in general take probably years. Now, sometimes a phase 1 trial can be done in less than a year, and then if it's proven to be safe, it can move on to phase 2. But I think the reference to, is it a moving target? Absolutely. Some trials are easier to enroll in than others, again, depending on how restricted the criteria. So some trials are very fast to enroll. Some trials take a little bit longer.
Thank you so much. We have time for just one last question. This question is asking, how can patients who are on Medicaid access clinical trials outside of their state? Are there any resources available for them? It can oftentimes be difficult for patients who are on Medicaid to receive care outside of their current location.
That is a very good question, because I definitely come across that barrier that if you have Medicaid, let's say I'm in Texas and being at Houston, that can be a barrier. That's where we would typically involve social work and our financial clearance center to see if there's a workaround, because oftentimes that Medicaid status in your home state could prevent you from, let's say, applying for our patient financial assistance program because you technically have insurance coverage, though it's Medicaid through your home state. So that's definitely a good question and complicated, but if that was a scenario that was presented within clinic, that's when I would loop in our social worker and financial clearance center to see if there was a workaround, or if maybe we could identify a similar trial that, let's say, we had available maybe in the home state or a place within the state that someone lives in terms of trial opportunities. There's neuro-oncologists. We are a rare type of doctor, but they're growing in number. And so that's something we try to do our best in, and try to network with maybe a neuro-oncologist closer to you and seeing what trial opportunities may still be within your state, so we could try to overcome that individual hurdle.
Thank you so much for your wonderful answer. Unfortunately, that is all the time that we have for today. Thank you again, Dr. Weathers, for taking the time to share your insight and expertise. And
Thank you so much for having me.
thank you. And thank you once again to our webinar sponsor, GT Medical Technologies, for their support of this program. And a special thank you to each and every one of you for joining us today. We hope that you've had an educational and informative experience. We encourage each of you to take a few minutes to complete our webinar survey by scanning the QR code on your smartphone or going to the link on the screen here. Your feedback is important to us as we plan for future programs. You will also be receiving a link to this survey and a follow-up email message, along with a webinar recording in a follow-up email in the next few days. If you're looking for more content like this, please check out our next patient and family meeting, Navigating Your Brain Metastases Care. This free half-day virtual meeting taking place June 17th will walk you through the diagnosis, treatment, management, and advancements in brain metastases care. Register for free using the link on the screen or scanning the QR code on your smartphone. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you again for joining us and enjoy the rest of your day. You may now disconnect.